This is Dr. Chris Robertson providing an overview of COPD. Again, when looking at any condition, you always want to refer to the evidence-based guidelines that will drive your care decisions. For COPD, that is the Global Initiative for COPD, or GOLD guidelines. You will see the website here, the link to the website, and the reference materials for or from GOLD are posted in course resources. Definition of COPD is typically a mix of chronic bronchitis and emphysema. However, it is noted here you've got progressive inflammation and airway limitation that is not fully reversible. Keep in mind that is one of the things that distinguishes it from asthma. You typically have the mix of chronic bronchitis and emphysema, and keep in mind smoking is the most common risk factor for both chronic bronchitis and emphysema. When you look at the factors that influence disease progression, you have to take into mind genetic factors, age, gender, lung growth and development, exposure to particles, which does go back to your social history, and so it's always important to know about employment or other hobbies or activities that may include exposure to various particles, socioeconomic status, obviously. Also, if the patient does have asthma or any type of airway hyperreactivity, chronic bronchitis, as well as infections. From a subjective standpoint, when you consider the history and physical with patients, from a history perspective, again, exposure. This goes back to tobacco smoke and occupational and environmental exposures. You've got a mix of chronic cough, dyspnea, and sputum production. Those are very key characteristic findings. Other things that you may hear about in the history or that the patient will share have to do with symptoms of orthopnea, P&D. Also, if a patient is being diagnosed with, if the patient already has been diagnosed with COPD, you want to make sure that you're asking about exacerbation history and any hospitalizations within the last year. And these are things that, again, will come up in their past medical history. Also asking about family history of COPD. That's extremely important. When you start looking at physical exam findings and objective data, you have those things here, which are your tachypnea, nail bed clubbing, and also diminished breath sounds. One of the things I do want to note when it comes to your history and physical exam findings, from a primary care perspective, there was a study that showed that among primary care providers, many felt that COPD was mostly a disease of men, started around age 60, and only 15% felt that treatment was useful in relieving symptoms and changing outcomes. And only 3% felt that pulmonary rehab would be beneficial. It's very important to keep this in mind because COPD is not mostly a disease of men. It doesn't always start around age 60. And obviously, treatment can be very beneficial in relieving symptoms, improving quality of life, and pulmonary rehab is underutilized and is something that we as primary care providers need to make sure we keep in mind. And so instead of always thinking about that classic male blue bloater and pink puffer, depending on how you were taught, the reality is there's typically a mix of bronchitis and emphysema, and the new face of COPD is a middle-aged woman with a history of smoking that also has symptoms. One of the things that I do want to note, you will see from the picture, is that it talks about some of the classic symptoms with cough, sputum production, frequent infections, the dyspnea, the wheezing, the pedal edema. I've had students in the past to ask, where does the pedal edema come from? So from a rationale perspective, when you're looking at long-term hypoxia, it's going to contribute towards pulmonary vasoconstriction, which can result in pulmonary hypertension. The increased pulmonary resistance against the right ventricle can lead to some right-sided heart failure or cor pulmonale. And so that's why you see some pedal edema in persons with COPD. So, excuse me, I progressed too quickly. When you start looking at older adults, keep in mind that they may have a blunted response to infection due to the decreased immune system. This is important because when you're dealing with patients who have chronic bronchitis or who have COPD, not necessarily chronic bronchitis, because you typically have a mix of chronic bronchitis and emphysema, but when you're considering a COPD exacerbation and a superimposed bacterial infection, keep in mind that in older adults, they may have a blunted response to infection. And so that is the rationale behind why we may treat an older adult differently when it comes to how we manage their COPD exacerbation. Alrighty, getting back to COPD history and physical. If a patient is diagnosed with COPD, I want to go ahead and make you aware that there are subjective tools that can be used to monitor the status and their exacerbation. This is something patients typically complete during their office visits every 2 or 3 months. And it's called the COPD assessment tool or the Modified Medical Research Council Dyspnea Scale. Depending on your setting, depending on the policy and procedure, you may see either used, could be completed before the visit or may be completed during the visit. With regards to diagnostics, it's important. Symptoms, so important. That is the subjective component. You also have to take into consideration risk factors and spirometry. With COPD, spirometry is required to establish a diagnosis. So spirometry in COPD is not only used for diagnosis, but it's also used to assess the severity of airflow obstruction. So it's going to give some indication about prognosis. From a follow-up standpoint, after the patient has been diagnosed, there is typically spirometry at least annually or more often if needed, that is used to make therapeutic decisions, but also used to identify rapid decline. And some COPD patients, based on the spirometry, if there's decline occurring that may not be as noticeable to the patient, this is one way that gives primary care providers an opportunity to catch it and manage prior to the patient becoming more symptomatic. Sometimes patients have symptoms that has become their normal and they may not recognize that it's abnormal because it is their normal per se. So from a diagnostic standpoint, the diagnostic criteria for COPD is an FEV1 FVC less than 0.7, and that says post-bronchodilator FEV1 FVC ratio of less than 0.7. So that indicates the poor or absent reversibility to bronchodilator, meaning that we have excluded asthma because there is poor or absent reversibility. And also with spirometry, you're not going to diagnose COPD during any type of what may be an exacerbation. And so understanding the pathophysiology of COPD, I want you to think about what these measurements are and what they would end up being in someone who has COPD. So when you look at the FVC, this is the forced vital capacity. This is the total volume of air that's exhaled in one entire breath. So someone with COPD, do you expect that to be normal? Do you expect it to be increased or do you expect it to be decreased? In this instance, it can be normal or decreased. When you look at the FEV1, which is the forced expiratory volume, this is the amount of air that can be, back up for a second. I want to go back to FVC. keep in mind these patients may have difficulty exhaling air due to air trapping, which you see in emphysema. All right, now let's move on to FEV1. So, forced expiratory volume. You have the air volume that can be exhaled in the first second of forced expiration. Should this be normal, increased, or decreased? You expect it to be decreased because keep in mind, or reduced, because these are patients who have obstruction, and so it's difficult for them to force air out of their lungs. And so the FEV1 FVC ratio is going to indicate obstruction, and it is going to be less than 0.7. When you look at the total lung capacity, again, this is the volume of air in the lungs at the end of maximum inhalation. So they're going to take a deep breath in and hold it. Do you expect that to be normal, decreased, or increased? And this instance is going to be increased. Keep in mind, you've got the air trapping, you've got that hyperventilation. And when it comes to residual volume, again, this is going to be the volume of air remaining after maximum forced exhalation. And you expect that to be increased due to the air trapping. This table here is taken from your text. Again, it shows pulmonary function testing and physical exam findings. It shows what you expect to see in someone with asthma and someone who has predominant chronic bronchitis and someone who has emphysema. For your information, you also have findings that are specific to persons with restrictive disease. So again, this gives you an idea of whether findings would be increased, decreased, or normal. And so think about why, based on the disease process. Back to looking specifically at COPD, the table here is a table from the old text. I still like to use it because I like to make a few points. Now, when we talk about COPD and when we talk about stage and when we talk about severity, you may see some of these terms used interchangeably. Currently, the guidelines will speak to the classification of COPD. That is the more general term. And so one of the things I want you to note is that depending on the stage or the severity or the classification of COPD, in all instances, the FEV1 FVC ratio is less than 0.7. What you do see as different is that the FEV1 varies based on the classification or the severity of the COPD. And so you see if a patient has an FEV1 that is greater than 80% of the predicted value, they have mild COPD. And from 50 to 79% of the predicted value is moderate COPD. And you can see what it is for severe and very severe. And so you do note that there is a difference between the two tables. The table on the left, when it speaks to moderate, it defines it between 50 to 79%, whereas the table on the right defines moderate between 50 to 80. So you see some overlap even between, or you see some distinction, varying distinction with one point. I do want you to reference the table on the right because it is more current. But again, I'm using the table on the left because I want you to see in all instances the ratio is less than 0.7. However, the FEV1, the percent predicted, is what indicates the severity or the classification with regards to, is it mild, moderate, severe, or very severe? And so again, this brings out that same point, and this is the current table in your text that also shows the FEV1 and the ranges, keeping in mind that with all stages of severity, the FEV1 FVC ratio is less than 0.7. Now, how do we diagnose COPD? There is an assessment tool that is used in diagnosis. So one, we have to use the spirometer to confirm the spirometry. We have to use spirometry to confirm the COPD diagnosis, and they have to have the post-bronchodilator FEV1 FVC ratio of 0.7. And then we have to assess airflow limitation, and that's when we're also going to use the FEV1 from the spirometry readings to determine the airflow limitation. And then we're going to evaluate exacerbation history, look at their symptoms and risk, and then we're going to determine which stage the patient is being assigned to. So let's go through this step by step. When we are diagnosing a patient, we want to start out with confirming the COPD diagnosis with spirometry. FEV1 FVC ratio of less than 7. Once that is done, we have to now determine what is their classification. In other words, what is their severity? And for this, we're going to look at the FEV1. We're going to look at their percent of predicted. And so after that, that's step 2. Now we're going to determine step 3. We're going to figure out what group they belong to. There are 4 groups, A, B, C, D. Determining their group helps you determine their initial therapy. And so how do we determine their group? I want you to think of it as though you are plotting a point on a graph. So again, the 3 steps to diagnosing COPD: confirm the diagnosis using spirometry, must have the FEV1 FVC ratio less than 0.7, assess airflow limitation. You want to determine their GOLD classification or their severity. I think this says, okay, their stage of disease or severity. You'll hear those terms used. And that is going to be based on their FEV1. Then you're going to determine their group. In order to determine their group, you're going to assess their symptoms and risk, and that is going to help you determine how to start their therapy. Symptoms will be determined based on the impact of their disease on their health issues, and risk looks at their risk of future events as far as their exacerbations, hospital admissions, or risk of death. So you'll see, based on the groups that they get assigned to, persons that are in group A typically have low risk and they have less symptoms, versus persons in group B, they are still low risk but they have more symptoms. And then groups C and D, these are your higher risk patients, and C, they're high risk but they have less symptoms, whereas D, they're high risk and they have more symptoms. So let's walk through how we determine groups. Again, I want you to approach this as though you are plotting on a graph. So first we're going to assess symptoms with the MMRC or the CAT score. And so we're going to start by seeing, based on their symptoms, are they going to be in the left or the right column? In other words, if they are in the left column, you can see here at the bottom where you have the MMRC. If they score 0 to 1 or on the cat, if they score less than 10, they will end up on the left side, either A or C. However, if their MMRC score is greater than or equal to 2, or if their CAT score is greater than or equal to 10, they will end up on the right side having more symptoms, which means they will either be in group B or D. So that's the first thing. We assess symptoms based on the questionnaire that the patient would have filled out. From there, we now assess risk, and we're trying to determine, is the patient going to be in the upper or the lower row? So the questions that we want to ask have to do with their hospital admissions. So we ask, how many hospital admissions have they had over the last year? If it is 0 or 1, or 0 to 1 exacerbations that did not lead to an hospital admission, they end up in the lower row, meaning they have moderate or lower exacerbation history or exacerbation risk. And so depending on whether you were right or left column, now you're determining upper or lower row. And then obviously if they've had greater than 2 exacerbations or greater than 1 exacerbation that led to an hospital admission, they would be in the upper row. And again, the lower row is 0 or 1 exacerbations that did not lead to a hospital admission, whereas the upper row is 1 exacerbation that led to an hospital admission or 2 exacerbations. So again, it's much like plotting on a graph. And so this is an example. Let's say we have a patient who had a CAT score of 8. So they're going to end up in the left column. So we know that they are either A or C. And let's say when we ask them about their history, they tell us that they've had 3 exacerbations in the last year. And so this places them in the upper row. So they are now in group C. So again, this patient will fall into group C based on their diagnostics. Other diagnostics or other things are important when you're diagnosing COPD. On a CBC, if it's indicated, you may see increased red blood cells. You may also see a higher hemoglobin hematocrit. Keep in mind, these patients may be dealing with chronic hypoxia, so they're going to produce additional erythropoietin. So you're going to have additional red blood cell production and polycythemia. Their blood eosinophil count may be elevated, which may give you an indication about exacerbation rates. And this would be in patients treated with a LABA without an inhaled corticosteroid. You want to evaluate electrolyte nutritional status so that you're looking at their total protein and albumin. Rule out any renal or liver problems. Chest x-ray may be normal in early COPD, but as they progress, you do see changes. Obviously, with chronic bronchitis, you see increased bronchiovascular markings. With emphysema, these patients may have a smaller heart, hyperinflation, flat diaphragms, and possibly bullous changes if indicated. So in other words, these are not testing that you would order routinely. If indicated and the CT is needed, you may see the emphysema, air trapping, or bronchial wall thickening. On ECGs, there may be some coexisting cardiac problems. We already talked about the right ventricular hypertrophy that contributes toward the pedal edema or the cor pulmonale. Again, the ABG would be used in the emergency department with flare. The other thing that's important in diagnostics with COPD patients is the alpha-1 antitrypsin deficiency. So that is the AATD screening. This is going to be important in patients where you have COPD in someone that's younger than 45 years of age. Typically in these patients, they have a blood relative that already has been diagnosed with, or if you have someone who reports this deficiency in a blood relative. And you also see this in patients who have emphysema, but they've never smoked. These patients will have COPD if they have this deficiency. And if they smoke, it makes it even worse. When it comes to the genetic genotypes that you see, you have the MM genotype, which means that it's normal, the MZ genotype, which means they are a carrier, and then the genotype, which indicates that they have severe deficiency of alpha 1. In patients that have this deficiency, you treat them just like any other patient with COPD. The only difference is that they would actually get infusion therapy to prevent damage. So, what are the goals of treatment in persons with COPD? You want to make sure that you reduce symptoms, that you're relieving symptoms, improving their exercise tolerance, and also improving their health status. You also want to make sure that you reduce their risk, specifically related to disease progression, preventing and treating exacerbation, and reducing mortality. These two pictures want you to take into consideration and recognize that COPD is a very vicious cycle. You have this cycle of hyperinflation, air trapping, and respiratory airflow limitation. This cycle contributes to poor health-related quality of life, and patients will often experience a downward spiral with regards to inflammation, obstruction, issues with mucus clearance, and exacerbations, and it can be progressive. And so again, you want to manage and reduce symptoms and reduce their risk, slow disease progression. It's important to be familiar with commonly used medications in COPD. You have this table in your text. This one was not taken from your text. This one was taken from the Gold teaching set, which is available and accompanies this lecture, if I'm not mistaken. And these meds are also listed here for your reference. I wanted to include this slide, and this was one of the slides that I highlighted in class from the perspective of cost. These inhalers can get very expensive. The costs here have likely changed since I've used this slide. However, it does reflect the daily use and the cost of one inhaler, and the fact that it can be very costly, particularly for your patients that may be uninsured or underinsured. And so sometimes you have to consider medication assistance programs. You also may have to consider using samples or what other resources may be available to keep your patients treated. So we went through the process of establishing, from a treatment perspective, what groups patients were in so that we knew how to initiate therapy. And so based on the group that they fell into, this is how therapy is initiated. And so you will see that here, if they are group A, remember those are patients with less symptoms and less risk, they are started on a bronchodilator, versus your persons in groups D that are going to have more symptoms and higher risk, they're typically on a combination of medication. From a primary care perspective, again, what you choose to manage depends on your comfort level. You may be okay managing someone in group A, whereas if they're in group D, you definitely want to make sure that they are referred to a pulmonologist. And again, you may be comfortable managing someone in group C or even group B, but you always have that option to refer them to pulmonology for management. So when it comes to the management cycle, it is a matter of getting them in to again review their symptoms, look at dyspnea, and also look at exacerbations, because we want to help manage their symptoms. We want to lessen disease progression and lessen decline, which also contributes towards mortality. And so you're going to be assessing their inhaler technique and adherence, all types of non-pharmacological approaches, particularly pulmonary rehab. This is something that we tend to overlook a lot in primary care, as well as self-management education. At all times, we want to adjust if that means escalating therapy, switching medications, or even de-escalating therapy, adjusting therapy. And so here is a follow-up pharmacological treatment algorithm for reference. Again, this would be something based on the patient's symptoms. You want to go by their symptoms. So are they dealing with more dyspnea? Are they dealing with more exacerbations? And so this gives you an idea of the decision-making guide that you can reference to help determine what changes could be made, what combinations of medications that you could try patients on. And again, even if you were making a change and wanted to make a change and schedule them with a pulmonologist, you've at least initiated a change until they can get in with the specialist. So again, you can use that or use this for that reference. And so here is a table that shows some things that are common to all persons. Smoking cessation is extremely important. When it comes to pulmonary rehab, persons in groups B, C, and D, you always want to take that into consideration and make that referral as recommended. Physical activity is something to keep in mind, and also with regards to your influenza and your pneumococcal vaccines. Smoking cessation is extremely important. After 5 years of no cigarettes, lung function returns to almost that of a non-smoker. And so it's important to make sure that in your patients that smoke or use tobacco, that you are asking at every visit, advising, assess, assist, and arrange as needed. There are clinical practice guidelines that speak about treating tobacco use and dependence, and you also have this algorithm for reference in your text. When it comes to follow-up, again, we talked about assessing risk factors. The things that are associated with readmission go back to no follow-up. A lot of patients who are admitted for COPD exacerbations do not follow up with their primary care provider and do not follow up with their pulmonologist. And so this contributes towards poor management after being admitted. That contributes towards further decline with respect to their symptoms and their risk, which then contributes to their mortality. And so we see those in patients who've had obviously previous hospitalization, decline in their FEV1, that have had disease duration for a longer period of time. Age and female sex are also things that contribute towards, or that we see in those persons with more frequent readmissions. And again, just to show that the trends speak to COPD hospitalizations becoming more costly. So it's very important that we not just manage hospitalizations in the acute care setting, but that in the primary care and outpatient setting, that we're doing what we need to prevent these readmissions. And so when it comes to how often do you monitor these patients, it's not uncommon for primary care providers, again, to manage COPD patients, or in all reality, there are times when patients may see their pulmonologist perhaps twice a year, but if they have an exacerbation, they're more likely to present to primary care as opposed to presenting to their pulmonologist. So typically for their routine visits, they can be seen anywhere from every 1 to every 6 months. The things you want to make sure that you're doing when they come into your office is that you're assessing their smoking status or their exposure, that you're assessing their symptoms and assessing their exacerbations, that you're also doing the annual spirometry. Again, as mentioned, you want to make sure that you identify a rapid FEV1 decline if it is present. If imaging and labs are done, you want to make sure that you're evaluating to see if there are any worsening. If supplemental oxygen is needed, typically this is indicated if their pulse ox is less than or equal to 88% after the 6-minute walk test. And if their FEV1 gets below 30%, you have justification for supplemental oxygen. And it's important that you know, in order for the supplemental oxygen to be effective, patients should be wearing it at least 15 hours per day. That is what has been shown to improve their mortality. When patients get to the point, or if they get to the point of needing ventilatory support, this is when they may need the non-invasive positive pressure ventilation, or CPAP or BiPAP. When it comes to referrals and comorbidity, keep in mind that in COPD, lung inflammation may spill over into systemic circulation, and so you may have some other systemic inflammation that contributes towards other diseases. So the more comorbidities that may also contribute towards more hospitalization and again impact mortality. So it's important to identify and manage other comorbidities and try as much as possible to minimize polypharmacy. So when you've got osteoporosis, depression, and anxiety, and also GERD, you can see how some of these things can be underdiagnosed and associated with poor health status and prognosis. And GERD can be associated with an increased risk of exacerbations. So these are some things you want to keep in mind, and you can see the diagram here on this slide. Now, when it comes to persons with COPD who have an acute exacerbation, it's important that you recognize what defines an acute exacerbation. So if there is a change in that patient's report of dyspnea, cough, or sputum production, that qualifies as an acute exacerbation. And they don't have to have all three. It could only be one. If it is a mild exacerbation, it is treated with a short-acting bronchodilator only. If it is a moderate exacerbation, you would add antibiotics and or corticosteroids to that. If it is severe, these are exacerbations that will require an ED visit or hospitalization, or may be associated with acute respiratory failure. It's important that you recognize those exacerbations and that you treat and manage appropriately. And again, understand that cycle. You've got the exacerbation, inflammation, infection. You've got destruction and remodeling of the airway, which further impairs airway clearance, which can then contribute to more exacerbations. So that's why it's important to make sure that you're identifying and managing these patients' exacerbations, but also to control their symptoms and decrease their risk. During acute exacerbation, when it comes to diagnostics, sputum gram stain culture and sensitivity if indicated, ABG if indicated, and again, that's something that's typically going to occur in an acute care setting. Your pharmacological treatments during exacerbation, you've got your short-acting bronchodilators with or without a SAMA. You've also got your corticosteroids, and again, antibiotics. Azithromycin is the most common. If the sputum is discolored, keep in mind, half of exacerbations are not bacterial, usually due to some environmental pollutants or viral. History is extremely important. When you do suspect bacterial, it's typically due to H. influenza, M. catarrhalis, or S. pneumoniae. And during exacerbations, you may have patients that require oxygen therapy or ventilatory support. It's important to recognize when hospitalization may be required. And so here are some of the things to monitor for with regards to when I may need to send someone from the office to the hospital, or if I'm triaging, when the patient may need to be hospitalized. So these things are listed here. Keep in mind that with acute exacerbations, time between exacerbations will shorten over time. And so when you talk about this spiraling downward progression with COPD, again, it's important for us to do our part as primary care providers with managing acute exacerbations or facilitating referral to the pulmonologist, facilitating adherence with treatment regimens. And also keeping in mind, patients need to understand it may take them 4 weeks to kind of get back to baseline after an exacerbation. Patient education with COPD is extremely important. Self-management is extremely, extremely important. Of all the social determinants of health, self-management or self-behaviors influences outcomes the most. And so self-management is important. So you need to educate your patient to make sure they're avoiding temperature, humidity extremes, limiting exposure to high levels of air pollution, no smoking in the home or any other confined environments or exposures, that they're mindful of occupational exposures, high altitudes, air travel, being mindful of their contact during flu season and limited exposure to people that are sick. Immunizations are extremely important. And if they do end up with influenza, making sure that they're treated early. And with pneumococcal, making sure that patients that are 65 or older, that they receive that every 5 years. Going over inhaler technique and adherence to therapy, you'd be surprised how many people may not be using their inhaler correctly. Making sure that they're cleaning their equipment properly. Pulmonary rehab should be considered as appropriately. Any physical rehab or physical therapy for those that is indicated. Talking to patients about how to better manage any type of dyspnea, shortness of breath, reducing bronchospasm, relieving dyspnea. Talking about cough techniques, chest physiotherapy, COPD support groups, also dealing with depression screening. SSRIs are safe in these patients, but also addressing any type of end-of-life care issues. This is taken from your text, which addresses the iceberg of COPD. And so recognizing that there's so much more going on than what we deal with sometimes in the office, but being able to touch on these components when they're needed, recognizing the various elements that influence COPD care, and providing resources, support, guidance, education, referrals that the patient may need based on managing this disease. And this concludes the COPD content.